The latest news from the American Board of Emergency Medicine is now available in a new format. Welcome to the ABEM General Podcast.
Hello, my name is Ernest Wang, and I'm a current director on the board of the American Board of Emergency Medicine. And I want to welcome you to ABEM Voices, a podcast where we interview emergency medicine diplomats who are making an impact in our specialty. I want to introduce today's guest, Dr. Michael Wilson. He's an ABEM certified physician, the AAEP representative, and Emergency Behavioral Health Portfolio Task Force member. He's an associate professor tenured in the Department of Emergency Medicine and Psychiatry at Carilion Medical Center in Roanoke, Virginia. And he's the director of Emergency Psychiatry and Associate Institutional Research Officer for Carilion Medical Center. Dr. Wilson is also board certified in addiction medicine, and he currently is the president-elect for the American Association of Emergency Psychiatry. He is the immediate past chair of the Coalition on Psychiatric Emergencies and has done substantial work in the area of behavioral emergency research. Thank you for joining us, Dr. Wilson. Could you please tell us how you decided to become an emergency physician?
Hey, thank you for having me. It's an honor to be here, and I hope I live up to that nice introduction. So how did I become an emergency department physician? You know, I'm sure just like you, there were many branch points on the way. I'll just say I always wanted to be that doctor when they say, is there a doctor on board? And here I am. It's kind of cool to be here.
Were there any mentors that played a significant role in shaping your journey? Any you'd like to shout out?
Oh, sure. If Dr. James Ellis is listening to this, Dr. J was an early mentor of mine, and a very colorful guy. I was an MD PhD student, so I spent, the normal amount of time, 4 years in med school, 6 years in the PhD. So I was there quite a while. And he would routinely introduce me as his 8th year medical student on my rotations. And so the poor patients, I still remember how they would sort of look at me and go, oh, wow, wait, isn't medical school 4 years? So Dr. J, if you're listening, thank you for everything.
Wow, sounds like just a wonderful mentor. That's great. We all need a Dr. J in our life, professional lives. What is your experience as an ABEM certified physician and ABEM volunteer been like?
The board is wonderful to work with. I think it's not really till you get a chance to work on a committee like that or look behind the scenes that you realize that folks like you really are doing it for one reason, that is to keep quality of care and standards high. I am certain that I'm a much better physician than I would have been if I was not ABEM certified.
Get involved with the American Board of Emergency Medicine. ABEM offers several volunteer opportunities to participate in exam development and exam administration activities. By participating in our assessment processes, ABEM volunteers play a crucial role in upholding the highest standards of emergency care and shaping the future of certification. Many ABEM volunteers have found that it is a rewarding opportunity that allows you to broaden your practice and give back to your specialty. Visit the ABEM website to learn how you can get involved. Together, we shape the future of emergency medicine. Now, back to the episode.
Thank you very much for that, and we really appreciate your expertise. You've chosen to specialize in an area that's really needed in this country, emergency behavioral health. Can you share your experience working with ABEM on the Emergency Behavioral Health Portfolio Task Force and how you chose this path?
Yeah, it is kind of a unique career path. If you'll put yourself in the shoes of my poor residency directors who had never had a resident interested in that, you can see why it's unusual, but badly needed. The latest estimates, and this is true, the latest estimates that if you lump together all behavioral emergencies and substance use disorders into the category psych, and we will because that's how the DSM does it, about 1 in every 8 or 9 of your patients coming into the emergency department fits into that psych category. This is uniquely an emergency medicine problem. We are the only place open after 5 o'clock and on weekends. We have to see these patients. So I give a great deal of credit to the ABEM task force who recognized this gosh, I believe this started in 2020, 2021. You can correct me if I'm wrong. When a task force began to meet, they prepared an application to ABMS and got the first ever focused practice designation in emergency behavioral health. Really cool.
This is such an immense issue, and those of us who practice, we see it every shift, every day. And these patients really deserve the best care emergency medicine has to offer. And ABEM is really committed to improving the care that they get. And so, thank you for your contributions.
You're
Um,
very kind. I'll just add to that and say, how ultrasound started out as a really good idea because we had a lot of patients that needed emergency ultrasounds. When that focused practice designation came in 2017, it went from, hey, this is a really good skill that every ED physician should know, or EM physician, to elevating the standard of care across the country and internationally. So thank you again for the work that you have done personally in getting this to FPD.
it's a team effort. And along those lines, I want to pick your brain, and if you could just share with the people listening on the podcast, what is your vision of how emergency behavioral health could be?
Yeah. So I'll break that up into kind of short-term wins and long-term, I hope, trends or wins. Short-term, I hope we get ABEM certified, knowledgeable folks who are able to deal with most of the psychiatric or behavioral emergencies that we see. I hope we get them into every ED in the country within the next 5 years. If we do that, we will almost overnight bring mental health care into places that don't have good access to mental health care or good access to addiction care. And that's the rural environments that most of us practice in. Long term, and this just may be a selfish hope on my part, but long term, I would like to get us to the point where our psychiatry colleagues are kind of like our cardiology colleagues. I don't call a cardiologist down to help me interpret an EKG or decide what I should do or how I should disposition a patient or what medications they need. I call them down for their expertise reserved for the specialized things that they can do. And I hope the same is true with our psychiatry colleagues as well. There's just not enough of them. And we
Yeah.
do need to save them for the patients that really need them.
Yeah, absolutely. Let's go there a little bit more. I'm just curious. And so, taking that analogy, right now, many of us will see a patient who with a chief complaint that is psychiatric or behavioral health related, and we make a determination that they're suicidal or not, and then we call our crisis colleagues, psychiatry colleagues, and that's kind of where the handoff is, and then there's a gap there. What can we be thinking about doing to fill that gap in care?
Yes, that's a great question. Let me start with what you can do on your next shift. So ACEP, in collaboration with the American Foundation for Suicide Prevention, created a point of care tool called the iCare 2. It has an E at the end, so I say iCare 2E, but it was really meant to be iCare 2. You can find that either on your ACEP point of care app or by going to the Coalition on Psychiatric Emergencies and looking under the Resources tab, and that's coalitiononpsychiatricemergencies.com. That is a step-by-step with drop-down menus how you would manage a suicidal patient. So that's what you can do your next shift. Now, I want to caution folks, if you haven't had any training in this regard, and you're trying to manage, 4 STEMIs, 2 strokes, and a couple of motor vehicle accidents, trying to do a suicide risk assessment is not going to be in the cards for you on that shift, right? You are going to have to leave that with someone who has a little more time and has done this before. And that's where I think the FPD comes in, because there's no data that emergency medicine physicians couldn't get if they had the time to get it.
I love how you brought that home in a real sense, for the practicing emergency physician.
Each year, more than 150 million people in the U.S. are treated in emergency departments. When they arrive, they deserve care from physicians who are highly trained, qualified, and prepared for anything. Like nearly 80% of the public, we believe physicians should lead emergency care. That's why ABEM certification is widely recognized as the gold standard in emergency medicine. ABEM is proud to promote the value ABEM certified physicians bring to hospitals and health systems. Proudly wear your green badge, buddy. Visit the ABEM storefront to order one today for you and your team. Check out our website for the latest resources to showcase your ABEM certification. Now, back to the episode.
I want to talk a little bit now about, you mentioned, American Foundation for Suicide Prevention, and I understand your research has been recognized by AFSP nationally. So can you tell us more about that and why that was important to you?
I was totally honored, and I heard just before the podcast, you also work with them helping raise money, doing some marathons. So thank you for your hard work. They're a great organization. They are dedicated to getting the number of suicides to 0 as soon as possible. I hope they succeed. They have an award program every year with ASAP. And so we were recognized a couple of years ago for innovations in suicide prevention. A lot of that has been, we were first nominated with the iCare 2 tool that I told you about, but what we actually won for was teaching people with lived experience to do something called safety planning. And let me back up, because if I just dive into this, it may not make a lot of sense. And I'll just say, we have this idea that the only thing we can do in the emergency department for a suicidal patient is call psychiatry or the mental health worker, whoever's on that day. And that's not true. There are actually 3 evidence-based interventions that have been shown in the ED to reduce subsequent risk of suicide after people leave. One of those is safety planning, not plan for safe discharge, but an actual 1-page form. Safety planning, it's a cognitive exercise. It takes anywhere from 20 to 45 minutes to complete. So again, you're not going to do it on a busy shift, but it cuts the risk of dying by suicide for that patient almost in half at 6 months. Just a 1-page cognitive intervention done in the ED, done in the moment. Now we said, our innovation is, we said, wow, that's a lot of time. And I don't know about your ED, but my ED, I can never find the social worker. They're busy on the floor with 10 other patients. What if we teach people who had a suicidal crisis on their own or in a loved one, what we call peers, folks with lived experience, what if we taught them to do safety planning? And it turns out in our very, very small pilot trial, and it had to be small because the IRB wouldn't let us have, they were very nervous about us doing this, but in our very small pilot trial, they did just as well, maybe even better than our psych nurses.
Amazing work. Congratulations. And I'm sure that the impact of that will be felt, and hopefully this will spread along with the FPD. So looking forward to that. I want to pivot a little bit. Much has been written about the rates of depression and suicide in emergency medicine. And in your experience, what are the risk factors, red flags And how is this related to or different from burnout? So several questions.
Yeah, very relevant for emergency medicine. We've lost far too many of our colleagues, dedicated folks. And this is, in my mind, one of the biggest issues facing emergency medicine. So let's talk briefly a minute, depression, burnout. They are different things. There are more expanded definitions. I'm going to really be overly simplistic. So please forgive me if you're a listener that has had some mental health training, because this will be too simple. But how I think of it is burnout is an environmental kind of stressor that emergency physicians are uniquely susceptible to because of the hours we work, because of the patients that we see, the trauma that we undergo, the psychological trauma that we undergo. Depression is a clinical condition. It's pervasive. It is a way of looking at the world. Again, there are distinct clinical criteria, but ask yourself, if this thing was different, if my job was different, if I didn't do this, would I feel better? Would things be completely better? If so, that's probably we're talking about burnout. If nothing seems to matter, now we're probably talking about depression. They're not mutually exclusive. Burnout is a huge risk factor for depression.
Thank you for that distinction. For me, the reason that I'm involved with the American Foundation for Suicide Prevention, is directly related to a colleague that I had who, ultimately, I think, rode the line between burnout and depression, and ultimately, unfortunately, succumbed. And this was, well over a decade ago. So it was not as, I think, out in the open or easily talked about. So I really think this is a great time that we can start, destigmatizing this. So I guess my next question, if I were an emergency physician listening to this podcast right now, and I'm having thoughts of suicide or depression, what would you tell me?
You're not alone. Um, I'll just say that, if we don't care for the people who are the caregivers, this country will be worse off. So to the person who may be listening to this is going, gosh, I'm a little past burned out. I think I may be suffering depression. You are not alone. There are real barriers to seeking help. I get that. Probably the biggest barrier is our own sort of, we can handle this culture. It's how we were trained. It's how I was trained. And we sometimes are the biggest barriers to our own well-being. But there are real legal barriers as well. In many states still, the fact that a physician sought mental health treatment has to be reported to the licensing board at the next renewal. That's not right. It's not fair. If there are any licensing board folks listening to this, I call on you to stop that archaic practice. It is wrong. But to the emergency physician who's suffering from depression, don't let that stop you. Your health, your well-being, and certainly your life, the ability that you have to impact patients, not just now, but years in the future, from being a happy, functioning, successful emergency physician, that depends on getting treatment today. If anyone wants to contact me offline, I'm happy to give or find resources wherever they are in the country. Of course, if you're feeling suicidal anywhere in the United States, please dial 988.
Dr. Wilson, thank you for that wonderful piece of advice. And I'm sure there's someone listening right now that's going to be benefited by your wise words. Thank you for that. We're coming to the end of our time. What's next for you?
Well, we're so excited about getting the focus practice designation implemented. So I've been seeing patients along with my psychiatrists for the last couple of months, and I look forward to doing that again, learning from them, but also blending in the emergency medicine perspective. We're going to keep doing the research that matters. We're going to keep doing the trials, and we're going to try and put more tools in the hands of more emergency physicians. So stay tuned.
Are you a medical student with a strong interest in emergency medicine? The Haley Academy offers rising second-year medical students an early introduction to emergency medicine, with mentorship from leading physicians, hands-on learning activities, and insight into the specialty's diverse career pathways. This is an in-person, all-expenses-paid, 2-week mentorship program where you'll explore important topics like healthcare disparities, community impact, and professional development while building lasting connections with mentors and peers. Visit the ABEM website to learn more and take the next step toward your future in emergency medicine. Now, back to the episode.
Well, congratulations, Dr. Wilson. On behalf of ABEM, we really appreciate your volunteer work, your subject matter expertise, and the difference you're making for not only emergency medicine in terms of patient care, but also for our physician colleagues. Thank you very much.
You're too kind. I'm just happy to continue the high standards of excellence that ABEM has laid out.
Thanks for tuning in to the ABEM General Podcast. Be sure to follow ABEM General so you never miss an episode.